Okay, so everybody ready? What have you guys been doing to prepare? If everybody could turn their cameras on, that'd be great.
Awesome.
Please. Thanks. Appreciate it. What have you guys been doing to prepare? Have you found the concept guide to be helpful?
Yeah.
Okay. Okay, that's what we're going to review. Okay.
Okay.
Alrighty. Okay. Let me share my screen. Hey, can everybody see that?
Yes.
Okay. All right. So here's all the concepts to be covered. They're all listed right here. This is week 4 at the top, week 5, and week 6. Now, I know we're in week 6, so only my Monday class has had the occupational, environmental, health barriers to learning, reinforcing health education. Okay, so you're going to get that in lecture this week. So actually reviewing your concept guide is what we're going to be covering in class this week. Okay. And then you have all your readings, so you don't have to go back. And don't forget these Canvas course readings. Okay. They're in let's see, week 4. You have 3 of them. Week 5, you have hospice and palliative care. And week 6, you have occupational environmental health. So don't forget about those. Okay. Same kind of exam, 50 questions, multiple choice, select all that apply. Don't be afraid to select all and select all that apply. Okay. There are questions that have the potential of all the answers being the correct answers. Right. So don't be afraid to select all that apply. Math, if you need math tutoring, please go back. And I've said this to several people already in my tutoring sessions. Please go back and to your week 1 announcement. I sent you an announcement with an attachment to Professor Bogart, who is a pediatric instructor who has an excellent, really basic tutorial on math. Okay. And there's some handouts that go with that. So I would suggest that if you have issues with math, go back and watch that. And if you're still having trouble, let me know. Okay. Obviously, this is not an all-inclusive study guide or concept guide. It was put together from your notes, from lecture, from your readings, from the Canvas readings, from your homework, your case studies. So used a lot of different resources to put the guide together. Okay. So I'm not going to go through every line of this. I'm just going to go through, kind of do an overview of this. Okay, without reading this, tell me about special vulnerable populations. Well, what additional risks do they have?
Diseases,
Chronic illnesses, yeah. What else?
STDs, tuberculosis, exposure to pesticides,
Substance abuse issues, mental health issues, right? Okay, they often have poorer health outcomes. Okay, and one of our special vulnerable populations we talked about was pregnant adolescents. Okay, what's the most important? Tell me about pregnant adolescents. Why are they so at risk?
Don't have resources.
Mm-hmm.
They probably not eating right.
Mm-hmm. They may not seek out prenatal care until later on.
Yep.
they
Right.
have higher rates of STDs.
Right. 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 Crime or violence, abuse is pretty prevalent in this vulnerable population, right?
Mhm.
Okay. When you're, let's say you're the home health nurse that's doing postpartum visit for a new teen mom that's just got home, what kinds of things are you going to be observing for that are on track or that could be red flags?
Her mental status.
Mm-hmm.
How she interacts with the baby.
Yep, that's a big one. That's a big one. Does she understand growth and development? Does she understand meeting the baby's needs, whether crying, bonding, eye contact, right? We talked about this in class, but I just want to reiterate it. What are the most important, what's one of the most important things for pregnant teens that we want to do as an intervention?
Keep them in school.
Yep.
Keep them in school. Keep them in school is the most important. When obviously we want them to have prenatal care early. Obviously, we want them to have dietary counseling and all of that. But most importantly, we really do want to try and keep them in school. Why?
The better education, they're more likely to succeed in.
Mm-hmm. Make better
Better.
decisions,
Mm-hmm.
right? Okay. Okay, let's talk about the LGBTQ. What are one of the first things we need to do before we care for this population? I refer back
Be
to
up
our.
to speed.
Hmm?
Be up to speed on the have information on the community.
Yes, yes, but one of the most important things we have to do is do a check-in of our own personal feelings, right? Our own values, our own beliefs.
Judgment.
We have to get over that hump, get over that discomfort if there is discomfort. Okay? Because we certainly want to try and create a trusting and open environment for them to be able to communicate their health needs. Right?
Mm-hmm.
So what kinds of, let's say we're interviewing them trying to do a health history, what kinds of questions may be non-judgmental? Give me some examples.
Ask them how theirs and their partner's relationship is.
Mm-hmm. And Michelle used the correct word, partner, right? We're not asking about boyfriends and girlfriends. We're asking about partners, right? That's pretty non-judgmental, right?
Yep.
Can you think of any other questions? When we're talking about adolescence, and homosexuality, what are some of the, well, remember that it's not that uncommon for adolescents to explore, right?
Mm-hmm.
And it's it to explore alternative lifestyles. So remember that. So if you're asked about, some of the concerns about adolescence, remember it's not that uncommon for them to think about it and talk about it and maybe explore. Okay? Talking in open, non-judgmental way as we're obtaining sexual social history, right? We don't make assumptions based on appearance or behavior, right? Rather, again, back to the questions, rather than asking boyfriend, girlfriend, partner, are you in a relationship? Okay. This tends to encourage the trusting of the healthcare provider and the client. And then this CDC, okay, they recommend annual screening for the prevention of STDs if the client has identified themselves as LGBT. Okay. So remember the annual screenings: HIV, syphilis, gonorrhea, genital herpes, and chlamydia. Those are the recommended screenings. Okay. And if the client is, let's say, at a more heightened risk, right, and that would be characterized maybe multiple or anonymous sexual partners, illicit drug use, then rather than annual, the CDC asks that that client be screened every 3 to 6 months. Okay. Okay.
Can you say that part over again? The one where they have to be screened for 3 to 6 months?
So if they're higher at risk, if they're
Okay.
more at risk, and the examples we give for being more at risk would be multiple or anonymous sex partners, or those that use illicit drugs in conjunction with sex, then the recommendation is to be screened every 3 to 6 months rather than annually.
Okay. Thank you.
Okay. Does that make sense?
Yes, it does. I didn't even see it in there saying it like that, but okay.
Mental illness, anxiety, mood, eating disorders. There are several conditions you need to be aware of, you're going to get asked about. And these are all the first 5 or 6 bullets are those different disorders. First is general anxiety disorder. I'm just going to highlight general anxiety disorder, phobia, OCD. Okay, each bullet represents a different one. PTSD, bipolar. Okay. And I try to really not tighten up, but really summarize these in kind of bullet points. Okay, so if you're not understanding these by reading what's in the paragraph or bullet, then go back to your, I think it's chapter 47 in your, well, let's look. Right here, Med Surg book, chapter 47, care of patients with anxiety, mood, and eating disorders. Okay. So, the one thing to remember, general anxiety disorder is a pretty big label. And the one thing to remember about that is there's lots going on. It's a general. Okay. So here's a description. Somebody who experiences persistent, unrealistic, or excessive worry about 2 or more life circumstances over 6 months. I mean, that's a long term, right? So that's how we classify a generalized. It's going on. Okay. One of the medications used to treat general anxiety disorder is buspirone. Okay. So remember that. Buspirone is usually treated. It's common. Okay. And remember though, if you're doing an assessment, you're doing teaching of a patient who's been put on this medication, initially it can cause rapid heartbeat and some anxiety. Okay.
Sierra's trying to get in the Zoom.
Who?
Sierra's been trying to get in. She's in the waiting area.
Oh, I see her. Okay. All right. I just let her in. Thank you. Another big one that is sometimes misunderstood is bipolar. Okay, what's bipolar? It's the episodes of extreme sadness, hopelessness, helplessness, right? And then the flip side, extreme elation, hyperactivity. Okay, one of the drugs used, one of the medications used to treat bipolar is lithium. Okay, I want you to know about lithium. Okay, if you're doing teaching with a client who's on lithium, patient teaching includes encouraging normal salt intake. Right? Well, there's several things you can read through. I'm
Did you
sorry,
say salt? Did you say salt? Normal salt intake?
it's right here. I'm highlighting it for you. Here's your patient instructions with lithium right there. Encourage salt intake is one of them. Right? They need to drink 2,500 to 3,000 mils of fluids per day. Try and take it with meals to avoid GI upset. Okay.
Got it.
So have an idea of lithium is common to treat bipolar. Buspirone is common to treat general anxiety disorder. And then don't forget about eating disorders. We didn't talk a lot about that. Okay. You have to go back and reread that section. It talks about a couple of different eating disorders, but we have to be able to recognize somebody that may be underweight for their height, right? And they're sensitive when you talk about it, right? Especially those girls in middle school and high school, the anorexia. Okay. So obviously the goal of a kid or somebody having a client having an eating disorder is to try and restore their nutritional health and normal body weight, right? Long-term goals, achieve sense of self-worth, self-acceptance, right? That's not based on just appearance alone. Okay?
Yeah.
Substance abuse, let's talk about that. Alcoholism. Okay? Here's a description of what kinds of things it may cause. Okay. Prone to malnutrition, skipping meals, right? We know that alcohol absorbs better on an empty stomach. It's a depressant, right? Okay, remember, this is important to remember here. All right. When you're trying to figure out or assess blood alcohol concentration, okay, remember, blood alcohol concentration is not just how much you drank, right? It's the concentration, the rate of absorption. Is there food in the system? Rate of metabolism, person's weight, person's sex. So there's a lot of factors. It's just not how much you had to drink. A lot of factors play into that. Okay. Then I want you to know about withdrawal. Okay, that's in here. Withdrawal. What is it? What might your client present with? All right. Obviously, the priority is to prevent he or she from hurting themselves or others, correct? What are some early signs of withdrawal?
Irritability, anxiety.
Pardon me?
Anxiety.
Irritability, anxiety.
Yeah.
agitation.
Yeah, early signs, irritability, anxiety, agitation. And then here's some interventions of what the nurse would do. Provide a low stimulation environment. Try and keep the client as calm as possible. Monitor vital signs. Report abnormal findings. Right? Try and reorient them to reality if necessary. If they're having hallucinations. Adequate fluid. Okay, so I'd like you to really be aware of what constitutes blood alcohol concentration. Okay, and there's actually some examples here. of absorption. Okay. 0.25 whiskey, 4 wine, 12 ounces of beer. So I'd like you to understand how blood alcohol concentration is, what factors affect it. I'd like you to understand the withdrawal symptoms of alcohol. Okay. What would with interventions? Okay. Going into and then the other part that is important is treatment. Okay. I'd like you to have a look at the treatment part of this. What's the goal of treatment? I mean, the goal of treatment is obviously to attain sobriety, but before that, what do you have to do? You have to have some sort of self-discipline, right? To be able to attain all those other goals towards sobriety, right? Tobacco. Okay, we know tobacco is associated with cancer, lung disease, heart disease. Secondhand smoke is toxic, right? Kids have a higher rate of respiratory infections, ear infections, asthma infections if they live in a smoking home. Okay. E-cigarettes. Okay. You got to remember that one of the biggest risks to kids around e-cigarettes is the poison, the oil, right? Oil is poisonous to these kids if they get into it. Okay. I'm just skipping through here. You need to read all of it. Okay, what about amphetamines and methamphetamines? These are stimulants. They can certainly be associated with cardiovascular complications, right? Stimulant abusers. What might, if they present to you, what might they exhibit? High body temperature, high heart rate, high blood pressure, requires emergency attention. Okay. Okay, let's get into the hospice and palliative care. Okay. So according to the WHO, what is the goal? The goal of palliative care, just to simply trying to improve the quality, not the quantity of life. Okay. And of course, hospice is end of life care, right? The goal of hospice to improve the quality of life, alleviate suffering, try and keep the client comfortable, right? And then making sure you're facilitating effective communication between the client and the family. There's lots going on for the hospice, right? With the patient, with the family. Okay, we don't want to be making decisions. If the client is capable, that's that the ethical principle of autonomy, right? If the client is able to participate in the decision making and the care plan, we want that, right? Simply making decisions for them is not helpful. And I'm just summarizing what's in here. Okay. What do you do with a family member who's not on board or who doesn't agree with the decisions that are being made? That's a real challenge for the hospice nurse. Okay, because the goal is to have everybody included. Everybody. Okay, you really have to dig in and figure out why they're not on board and try and help communicate to them what's going on. What are their feelings? Maybe they've recently had a death in their own family. All right, but the goal is to have everybody on board. So that's what the hospice nurse, everybody on board with the plan. Right? So that's what the hospice nurse, that's what she strives to achieve. Okay? Maintaining dignity, self-esteem. We don't want to keep the client so sedated, they have no idea what's going on either. Okay? We want them to interact, be part of the decision-making team. Yes, family's important, but your client's the most important, right? We need to, if they have directives, right? If they have advanced directives or they've directed what they want, that has to be followed. If the family member doesn't agree with that, the client's wishes have to be followed, right? We talked about that in class. Okay. Interventions focused on symptom management, comfort care. Pain control is a priority. Okay, we're not worrying about addiction at this point, right? Controlling their GI distress from the pain medication. Okay. Let's say a client has said, I don't want any more feeding tubes. I don't want any more treatments. And the family's saying, no, you can't let them starve or whatever. You have to step back and try and explain to the family. And that's what this last right here.
Can you be quiet?
Sometimes dehydration and terminally ill somebody needs to mute with the background noise. That sometimes you can't, if the client has said, I don't want any more feedings, that's okay. I mean, sometimes dehydration, in terminally ill patients, has been shown to actually decrease the pain versus all that the food in there trying to digest and go through their GI system. Okay? And explaining that to the family. Understand the stages of grief. Everybody goes through the stages of grief differently. Okay, so here's some information on the stages of grief. We covered that in class. And then your shine, strokes, respirations. That's typically at the very end. What does that look like? Slow breathing followed by periods of apnea. That's important for the hospice nurse. Okay. Coroner. Coroner will investigate death when there's a question about the cause of death. Okay. Coroner doesn't investigate every death. Like they wouldn't investigate every single death that happened at home or every single death that happened in a hospital. Okay. But they would investigate a couple things. Okay. That if a person doesn't have a primary care provider, if it might be a suspected suicide, or if it was a death from injury. But not all cases, that's the point, all cases are investigated by a coroner. If you investigate every death that happened in a home, what about the hospice client that dies in their home? That's not a coroner case. Okay? Let's move to spirituality and culture. Okay. I focus a lot on culturally competent care because it's extremely important in our profession that we practice culturally competent care. And it all starts with, before we even talk about it, culturally competent care requires us as nurses to assess our own values, right? Our own beliefs, understand our own culture, understand, and then we can understand other cultures. All different cultures have their own values, beliefs, practices, right? They have their own way of life. Okay, and so providing culturally competent care requires that we can incorporate as much of their beliefs and values and practices into that plan of care. Right? We may not be able to do everything, but we certainly can do what we can. Right? So we all work with different kind of cultures that have lots of different, it's very different from ours. Okay. But culturally competent care means we can look through the eyes of our culturally diverse client, right? See the world how they see it, right? That means means checking our own stereotypes, checking our own biases, right? We can't make any assumptions. Our culture is not important than anybody else's. Okay. Some examples. You have your Jehovah's Witnesses, right? Let's say they have to have surgery. Okay, well, we have to understand with them, and this is just an example of giving in here, that they don't get blood products. It's forbidden in their culture. Okay. Clients that eat a kosher diet, right? That means they can't have pork. Right? What about the Native American? I'm just giving specific examples. What about the Native Americans who don't do eye contact? They look down at the floor. That's their culture. They consider direct eye contact rude, disrespectful. Right? And then with regards to cultures, different cultures are time oriented. Some are future, some are past, some are present. And then this bullet gives you an example. Let's say present. If you are a culture that's present, you're in the here and the now. Okay? That's great. But what tends to happen? They don't plan for the future. Right? And same with past. If you're past oriented, you're not planning for the future. Okay. When is cultural competence finally attained? It's when we, as nurses, are making conscious attempts to learn about people's cultures and try and see the world through their perspective. What do you do? What do you do if you don't? Let's say a client comes in and let's say they say, I don't speak English or no speak English. What do you do?
Get an interpreter.
Find an interpreter. Right? That's the best thing to do. I mean, I guess, if there's no interpreter available, see if a family member might speak English that you can communicate with them. Right? Ethical and legal issues, right? The first step, obviously, think of your nursing process. The first step in ethical decision making is you have to have an issue, right? What are the issues that are being faced? Right? That's your assessment. What's going on? Right? Ethics committee. Okay. What does ethics committee do? They process ethical dilemmas and make policy recommendations. They're not part of the direct care orders. That's not what they do. A committee is to talk about different cases. Okay. Ethical principles, right? Beneficence. Remember, beneficence, we do good. Okay. So we do the most good possible within the circumstances, right? So maybe with a hospice patient, that includes providing adequate pain control. Do good. Right? Non-malfeasance is another one. Do no harm. It's all right in here. Do no harm. Okay, the example we give with non-malfeasance is, and it was in your quiz, one of your quiz questions. Let's say you're catheterizing a patient and you contaminate the sterile field. What do you do?
Get a
Get a
new
new
kit.
kit, right? Do no harm. We don't want to cause an infection. Okay. We just talked about this in the hospice and palliative care section, respecting the client's right to stop treatment. That's respecting their autonomy. That's an ethical principle, autonomy. Letting them having them participate in their decisions. Okay. And then when we talk about legal issues, documentation, when we're documenting, descriptive, objective about what you see, hear, feel. Okay. You can't see, part of documentation can't be, they appear to be agitated. Are they agitated or are they not? Make sense? Documentation is not about your own personal judgment. Okay. You can't infer something without factual data to support it. Right. So using terms like it seems or appears is not acceptable because it's you're stating an opinion. You have to be factual. Vital signs are pain level on a scale of 1 to 10 is 7. Description of the wound. Okay, those are objective, factual data points that need to be documented. Okay. Then the other thing we talk about with regards to legal and ethical issues that can, I mean, we face lots of ethical issues in our workplace, but what if you're floating? What if you're floating in the hospital to a place that you never have worked before? Right? We know that floating is acceptable, right? Hospitals or places of work do it all the time for understaffing issues, right? So legally, you really can't refuse to float. Okay. However, let's say you're floating, you've been working with adults and you get floated to the pediatric unit. What's the conversation you want to have with the head nurse or lead nurse? You want to know what's going to be expected of you, right? And can you safely perform those tasks? And maybe you come up with a list of what you can safely perform, right? Because you don't want to be practicing outside your scope, right? So maybe you identify, well, I can take vital signs, I can do INOs, right? So think about that. That happens all the time, does it not? Has anybody been floated to a unit that you've never worked on before? It's scary.
Yes.
Right. It's scary. But you have to continue to try, you have to protect yourself. What tasks can you safely perform? And what is totally out of your scope? All right. Then occupational health. Kids are the most vulnerable to environmental hazards. Think about the question you had. Well, for some of you that haven't had it, one of your quiz questions is, who's the most vulnerable? Kids. Why? They're so close to the ground. Right? They pick up everything. They put everything in their mouth. Think about the lead-based paint on windowsills. They eat paint chips, right? Right? But kids are much more vulnerable to environmental hazards. Okay? Think of everything we have in our houses. Think of all the gardening, cleaning supplies, right? I mean, there's so much. We'll go through this all in class. Any of you in my Monday class, have you already heard all of this? Okay. So this is just a summary. Okay. What if you're an occupational health nurse and you're responsible for the health and safety of all your employees and you work in a big hospital? Right? The occupational nurse needs to have an understanding of what kinds of workers you have, what are their job responsibilities, are they trained on protective equipment, are they trained on how to dispose of hazardous material, or whatever their job description is. That occupational nurse has to ensure that the person's a trained. What if you have a high absenteeism rate or lots of people complaining about, let's say, back pain? Are you assessing their ability to lift? Right? Are they doing it correctly? Okay, think about it. Think about it in a hospital. Think about how many job descriptions there are, how many responsibilities there are within those job descriptions. Right? Everybody requires different training for different areas. Okay? I mean, think about it. No workplace is risk-free. Let's say you work in a fast food place. Well, risk of burns, risk of slipping, risk of fire. Let's say you work in a bank. I don't know, risk to fall, risk for excuse me. No, no workplaces is risk-free. Let's say you have to walk up some stairs to get into the bank. There's a risk for a fall, right? And you just had a snowstorm and nobody cleared the ice, right? My point is there's no work area that's risk-free. Okay, every industry has hazardous risks. Okay, and we'll cover occupational environmental health more in depth this week. What about client teaching? I think that's our last concept. One of the most important learner-related barriers is literacy, low literacy. What does that mean? What does low literacy mean? They don't understand, they may not understand what you're talking about in your teaching or your day-to-day activities with them on the unit. Okay. Why does this happen? Well, there may be language barriers, maybe a cultural barrier. Oftentimes, patients are embarrassed to admit that they can't read, right? Or they don't understand. Okay. One way that we can assess the ability to read and comprehend is by giving them something, giving them a printed instruction and asking them to read it and making sure they acknowledge it. And then we have 3 domains of learning. Okay. We have psychomotor, affective, and cognitive. We all learn in all those 3 ways. Cognitive is your thinking about the material, taking it all in. Your affective is how you feel about it. Let's say you're teaching clients about a certain topic that may be controversial. How do they feel about it? That's going to affect their learning. Then psychomotor. This is in here. Focused on psychomotor is performing. Okay, psychomotor is simply performing the task, having the ability to perform the skill and practice it. That's the hands-on. So you have to be able to distinguish between all 3. And we'll go over that in class. Okay, but 3 ways of learning: cognitive, thinking; affective, feeling; psychomotor, doing. Okay. And then when do we start discharge planning?
On a mission.
On admission, right? Because we're always planning for the discharge and what they might need. Okay. So that's a overview of all the concepts. Helpful? Yeah. If you have a good understanding of the concept guide, you'll do fine on the exam. But remember, we're in the next gen mode. So your exam questions are going to be clinical questions, right? It's taking your knowledge and putting it into practice. So it's clients presenting with this. What do you do? It's the exam is clinically focused. Critical judgment. And it brings in your med surg, it brings in your peds, brings in your OB. All right, so questions. You guys will be fine. You guys will be fine. You'll be fine. The fact that you're even here this morning, you're going to be fine. You're fine. And thank you. Thank you for taking the time. I really appreciate it. I hope it was helpful. Now, listen, I think you guys are pretty much all my students, which is great. If you get into the situation where you need some extra tutoring before your exam, give me a heads up and we can get on Zoom and talk about any concepts you're struggling with. Okay? But first, go through your concept guide, your review guide, then go back and if you're not understanding, go back and do the readings for that part of that, whatever you're not understanding. If you're still having trouble, get in touch with me. We'll get on Zoom before your exam and we'll go through it. Because I want everybody to ace this exam.
I think the only issue that I would say I would have had is getting better is I understand what you say when you be like, this is more of a clinical setting. Like you actually do what you should do. You talk to us in a medical term. You don't say closest to the floor. You say proximal, you know. So the problem is we're not getting that nowhere else. So, and then we didn't get medical terminology as a class. So it's constantly sprinkled in there a little bit, but you're actually testing us with that. And that's where it gets a little different when it's time to read those clinical setting type questions.
Yeah. Well, that's what your boards are good. That's what NCLEX is, right? So yes, it is difficult making that transition. I get it, to being clinically focused, but this whole next gen, I mean, it's great to have all the knowledge, but what if you can't go out there and practice it? Right? I mean, what if you can't practice? So that's why I know it's a hard shift, but it's putting your clinical judgment skills into practice here. Because when you get out and you're a nurse, it's clinical. All your settings are clinical now. Right? So I'm trying to help you think that way. It's great to understand, if you're working with hospice clients, it's great to understand that what's the focus, comfort care, self dignity. It's great to understand that. But when you're actually working, when you're in the clinical setting, so that's that whole next gen focus. So I know it's a hard transition, but it's actually transitioning to what you're going to be doing when you pass your boards. Practice setting, clinical judgment based on your knowledge. You guys are all smart. You're fine. Okay. Questions? Is this helpful?
Yes.
All right, I'll get the recording this morning and I'll post it. But for those of you that haven't had class this week, we'll go through in-depth occupational, environmental health, teaching, and barriers to learning and all that. Okay? What I have on the concept guide is it's just a summary. And that's what that whole guide is. It's a summary. These are the important things. If you pull out each concept, here's the important information regarding each concept. Okay? You guys are fine. You'll be fine. Okay. Hey, listen, what's today? Wednesday? Have a good rest of the week. I'll either see you in class or see you next week, but remember to reach out to me if there's something you're not getting. Okay? I don't want you to go into the exam thinking, oh, I hope they don't ask a lot of questions on ethics because I really don't understand it. Get with me before that and let's go through it. All righty? And
Okay, thank you.
thanks for attending this morning. I appreciate it.
Yes, ma'am.
Bye.
Okay.